The three with the least systemic bioavailability are these three on the left-hand side of the left-hand slide: fluticasone furoate, mometasone furoate, and fluticasone propionate. And they have negligible systemic bioavailability, which means they don't cause steroid problems. Beware of the one at the right-hand end, betnazole, very effective in the nose, but 100% absorbed, so short-term use only. And you can reassure parents using data like the graph on the right. And this looks at the growth over 12 months of children who have placebo or who have mometasone furoate nasal spray. And it shows that A, there is no growth impairment with mometasone furoate, and growth impairment is what you see with corticosteroid overuse in children. It's a very sensitive monitor. And B, actually, the children on mometasone furoate grew a little bit better, significantly better by 12 months. And I suspect that was because they were sleeping better and because we make growth hormone while we sleep. What are the recommendations in India? Here they are from the Indian Academy of Pediatrics. They suggest you can use mometasone furoate from age 2 onwards and fluticasone propionate and furoate from age 4.
There was a study talking about mometasone and fluticasone, and they saw that the efficacy was almost the same.
So when do you prefer using intranasal corticosteroids over oral antihistamines?
As I said in my talk, intranasal corticosteroids are the only drug that really reduces congestion. So in the congested patient, I would use them. I would also use them in the patient with more severe persistent disease, because they work better for that, and in the patient with comorbidities, and that includes asthma.
All right, thank you, ma'am. Dr. Deendayal, if you have anything to add on the same question.
Can you repeat the question, please?
Sure, sir. When do you prefer using intranasal corticosteroids over oral antihistamines?
Intranasal corticosteroids is the drug of choice for persistent type of allergic rhinitis, because you need to use it for longer periods of time. And antihistamines have role only as and when the symptomatology worsens, if you want to add on. But intranasal corticosteroids for a longer period of time manages the thing symptomatically, and any of the subclinical inflammatory changes that have taken place would be most of the time kept under control. In fact, there's another question that was always asked is, how long do you give it in children? I have even used it to a maximum of 1 year in children with no side effects, especially mometasone.
All right, thank you, sir.
I have data from a trial I did using fluticasone propionate for 2 years in children, no side effects, no effects on growth. I think you probably need to use these things as long as the patient needs it. But I would argue that for children, especially those who present with rhinitis fairly early, we should be doing much more allergen immunotherapy. We can do it with tablets now, even for house dust mite under the tongue, because that can prevent asthma development. And that's really important. And India's children deserve this. If you can afford it for them, it will be worth it.
Thank you, Professor. So, Dr. Deendayal, as you rightly said, that the duration of using intranasal corticosteroids is a commonly asked question, and we've seen that today as well. So I will skip that question. The same question is, does mometasone also work for adults?
I didn't hear the last word. Does mometasone also work for
adults?
Adults. Do you want me to answer?
Sure, Professor.
They are both effective. There's almost nothing to choose between them. And I think it depends on which one the patient likes to use. But they both do work. They both work in children. They both work in adults.